Welcome. Today we're delving into megacolon, a condition that affects the large intestine, or colon. We'll explore what it is, what causes it, how it's diagnosed, and what can be done about it. So, buckle up as we journey through the ins and outs of megacolon. Let's talk about what sets megacolon in motion. The causes are diverse. One major player is Hirschsprung's disease, a congenital condition where nerve cells are missing in the colon, hindering its ability to push waste forward. Other causes include inflammatory bowel diseases like ulcerative colitis and Crohn's disease, infections, certain medications, especially those that slow down bowel movements, and even conditions like Chagas disease can also lead to megacolon. In some instances, the exact cause remains a mystery, termed idiopathic megacolon. Now, how does megacolon actually develop? In essence, it's a tale of impaired colon function. When the colon's ability to move stool effectively is compromised, fecal matter accumulates. This build-up causes the colon to stretch and widen, hence the mega in megacolon. The weakened muscles of the colon wall further exacerbate the issue, creating a vicious cycle of dilation and impaired motility. This distension can then lead to a cascade of complications, which we'll discuss later. Epidemiologically speaking, megacolon's prevalence varies depending on the underlying cause. Hirschsprung's disease, being congenital, is usually diagnosed in infancy and affects about 1 in 5,000 newborns. Inflammatory bowel disease-related megacolon is tied to the incidence of IBD itself. The frequency of megacolon caused by other factors, such as medications or Chagas disease, depends on exposure to those risk factors. Knowing this distribution helps us understand who's most at risk and how to target prevention efforts. What are the signs that someone might have megacolon? The most prominent symptom is severe constipation, often resistant to typical treatments. Abdominal distension, causing the belly to appear swollen and uncomfortable, is another key indicator. Patients may also experience abdominal pain, nausea, vomiting, and a general feeling of being unwell. In severe cases, complications like fecal impaction and even bowel perforation can occur, leading to more dramatic symptoms. Diagnosing megacolon involves a multi-pronged approach. A thorough physical examination is the first step, followed by a review of the patient's medical history and symptoms. Imaging studies like abdominal X-rays and CT scans are crucial for visualizing the dilated colon and ruling out other potential causes. A baryenema, where barium contrast is introduced into the colon, can also highlight areas of narrowing or obstruction. In some cases, a colonoscopy, involving a flexible tube with a camera, may be performed to directly examine the colon lining and obtain biopsies for further analysis, especially if inflammatory bowel disease is suspected. For suspected Hirschsprung's disease, a rectal biopsy is often performed to check for the presence of nerve cells. Megacolon isn't always a one-size-fits-all condition. It can be classified in a few ways. We have acute versus chronic megacolon, depending on the speed and duration of symptom onset. We can also categorize it based on the underlying cause, such as toxic megacolon, associated with severe inflammation, or pseudo-obstruction megacolon, where there's no physical blockage, but the colon behaves as if there is. Understanding these classifications can help guide treatment strategies. Managing megacolon focuses on relieving symptoms and addressing the underlying cause. Initially, treatments often involve enemas, stool softeners, and osmotic laxatives to help clear the accumulated stool. In some cases, manual disimpaction, where a healthcare professional manually removes the impacted stool, may be necessary. For megacolon caused by inflammatory bowel disease, medications to control inflammation, such as corticosteroids or immunomodulators, are typically used. Surgical intervention, such as a colectomy, a removal of part or all of the colon, may be required in severe cases or when other treatments fail. In the case of Hirschsprung's disease, surgery is the primary treatment, involving the removal of the aganglionic section of the colon and connecting the healthy colon to the anus. Preventing megacolon can be challenging, as many of its causes are not preventable. However, certain measures can reduce the risk. Prompt treatment of inflammatory bowel disease can help prevent the development of toxic megacolon. Avoiding medications that can slow down bowel movements, unless absolutely necessary and under medical supervision, is also important. Ensuring adequate hydration and fiber intake can promote healthy bowel habits and reduce the risk of constipation-related megacolon. The prognosis for megacolon varies greatly depending on the underlying cause and the severity of the condition. In many cases, with appropriate treatment and management, patients can achieve significant symptom relief and improved quality of life. Recent research is focusing on developing more targeted therapies for inflammatory bowel disease and improving surgical techniques for Hirschsprung's disease. Scientists are also exploring the role of the gut microbiome in megacolon and investigating potential probiotic therapies to improve colon function. These advances offer hope for even better outcomes for individuals living with megacolon in the future.